Record.
This meeting is being recorded.
My name is Don Fleming, and I'm the Senior Education Coordinator at CAS, and I'm pleased to welcome you to this Lunch and Learn presented by CAS's Research and Scholarship Committee. The presentations in this series focus on nursing workforce, and we'll get Shamel's slides back up, but I'll continue with my introduction. There we go. I would like to start with land acknowledgement. CAS's national office is located on the traditional territory of the Algonquin people, and we would like to acknowledge and pay respect to the Algonquin people who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region and in all regions across Canada. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. Lunch and Learns are a popular tool in academia to encourage scholarship. Faculty members come together during their lunch hour to share their work and to network. CAS's webinar series aims to recreate this collegial feel of the Lunch and Learn and is intended to serve as an inspiration and a networking opportunity. Nursing faculty from across the country, and today from another country, present on a scholarship project and discuss methodologies, successes, or challenges they have encountered in their work. We'll be recording today's session, and we'll begin with a presentation from our speaker and then conclude with a 15 to 20 minutes of an answer. So in this session, we'll hear from Shamel Rawls-Sands. You would have read her bio when registering, and the title of her presentation is Examining Nurse Turnover in a Small Island Developing State During the COVID-19 Pandemic, Context Matters. Shamel, we look forward to your presentation.
Good afternoon, Dawn, and good afternoon, everyone. Bonjour to my French colleagues. So I'd just like to thank Dawn so much, first of all, for this invitation to share during CAS's Lunch and Learn. Engaging in my doctoral research has certainly been a rich learning experience, and I look forward to a robust conversation at the end of the presentation. I'm grateful for your interest in what I have to say and share. So in this presentation, I will share my personal experience of navigating multiple, what I call opportunities and threats, as I planned and conducted my doctoral research, and specifically talk to you about some of the things I encountered in the context of a small island developing state during a protracted pandemic. So to begin with, just a brief overview of what it is that I'm going to do as I progress this afternoon. So I think it's good for me to tell you a little bit about myself, to position myself with research, the research process, and my area of focus. And then I'm going to describe my personal experiences, planning and conducting some of the opportunities I encountered, as well as what I consider threats, discuss my key takeaway from the entire process, and then outline some recommendations that might perhaps mitigate potential challenges for other doctoral students and even perhaps other researchers in the future. So let's begin. So approximately 400,000 citizens and residents, predominantly of African descent, call the archipelagic nation called the Commonwealth of the Bahamas their home. And this small island nation is comprised of nearly 700 islands and keys. However, only about 30 of them is inhabited. And so I had the privilege of being born on the island of New Providence here and raised in the capital city of Nassau until I moved to Grand Bahama. So I moved from Nassau to Freeport, Grand Bahama, and there is where I completed my high school education. So I spent my formative years with my grandmother, and as a young child, I watched and admired her as she cared for new mothers and their infants. And so by the time I was done with high school, I had decided, because I knew that I too would make nursing the correct choice for me. And in this photo in this slide is a photo of myself being held by my grandmother Mavis Simonette Roll, who was a registered nurse and midwife herself. So over time, nursing has become more than a career to me. I now refer to nursing as my ministry, in which I feel compelled to advocate for the patients, for the families, communities, as well as the nurses entrusted with their care. And so it has been 35 years now since I began my nursing journey. I spent 18 years working as a registered nurse, primarily in acute care settings in the public and private sectors of the Bahamas before I accepted a full-time faculty position at what was then the College of the Bahamas, now the University of the Bahamas. And while I was at the University of the Bahamas, I taught in the undergraduate and post-RN nursing programs as a full-time member of faculty for 9 years prior to leaving to pursue my doctoral studies in 2018. And so over these years, I have voluntarily left positions in organizations. Sometimes I have been an enthusiastic leaver, and then other times I left more reluctantly. I have considered leaving my home country to seek employment as a nurse abroad. I even considered leaving the nursing profession, particularly in the early stages of my career. My personal observations and experiences and those shared by nursing and non-nursing colleagues, and then more recently nursing students, have shaped my views about nurse retention and turnover, and have in part been the impetus for my doctoral work. These experiences have fueled my desire to address the absence of a comprehensive, organized effort to address nurse retention in my home country, the Bahamas, and the dearth of empirical data specific to the local context on which to base comprehensive retention policy have all come together to fuel my desire to complete this doctoral work. And so during my study, the ongoing issue of nurse turnover, nurse retention was further underlined by the impact of the COVID-19 pandemic. My doctoral work is deeply personal and will continue, I believe, to inform my life's work. So my first step as a nurse researcher was to return to the place that has shaped me professionally and personally in some very profound ways. My core research interest is centered on health, human resources, specifically nursing resources, employee well-being, and policy planning. And so I returned to the Princess Margaret Hospital, which was my study center, and my doctoral work examined the intersection of job demands, job resources, well-being, and the COVID-19 pandemic, and how they together influenced or did not nurses' turnover intentions in the Bahamas. And so just a quick background, we are all aware here that of some of the impacts of COVID-19 and the continued pandemic, but nurses in the Bahamas, like their colleagues around the world, have had to navigate the varied effects of the protracted COVID-19 pandemic on their personal lives, on their work content and context. And one of the effects was the exacerbation of already low or limited job resources, things like staff, medical and surgical supplies, coupled with high demands, for example, their workloads. So these conditions, based on the literature said to me, potentiated negative impacts on nurses' well-being and increased turnover intentions that could lead to the loss of essential nursing personnel to provide quality patient care. Anecdotal evidence suggested that these conditions might also push Bahamians to leave their positions here in the Bahamas. And so the dearth of empirical evidence regarding the influence of specific particular job demands, job resources and well-being on turnover intentions among nurses in the Bahamas during the COVID-19 pandemic was what helped to drive me and propel me through conducting this research. And so simply put, my purpose for this research was twofold. First, to examine the influence of job demands, job resources, and well-being on turnover intentions of nurses in the Bahamas, particularly those employed in public acute care settings in the hospital, the largest hospital in the country, during the COVID-19 pandemic. And then two, I wanted to identify key predictors of nurses' turnover intentions. So for the purposes of this study, the job demands included things like the job demands were any stressors that would put more pressure on the nurse, whether it was physical or psychological. And so the variables in this study included the COVID-19, fear of COVID-19, and then workload, and the job resources, which were variables that contributed to nurses either physiologically or psychologically being able to alleviate some of the stressors. And the variables that I was concerned with included things like managerial support, collegial support, and in this context, it was particularly concerned with support from physicians to nurses. And then the other job resources included material resources and then human resources. The well-being variables were anxiety and stress, and these variables were based on a review of the literature. So I used a cross-sectional descriptive design, and I used stepwise multiple linear regression to conduct my analysis. And I also used bootstrapping so that I could test mediation, because I had a couple of hypotheses. First, I hypothesized that the job demands would negatively influence nurses' turnover intentions. I also hypothesized that I hypothesized that high job demands and low job resources would negatively impact turnover intentions among nurses in this acute care facility. And then I also hypothesized that the job resources, high job resources and low, high job demands, and low job resources would negatively impact nurses' well-being. That is, that it would increase their stress and anxiety levels. And then finally, I hypothesized that the nurses' well-being would mitigate the job demands and job resources and their impact on turnover intentions. Well, some of the findings were surprising, particularly based on what I had found in the literature before. What I did find was that managerial support mattered. While workload, even though the nurses in this study reported high workload was not a predictor of nurses' intent to leave. Managerial support was. Collegial support was fairly high, and so, but that did not predict turnover of nurses' intentions. COVID-19, fear of COVID-19 did not predict. So of all the variables that I examined, the well-being variables of stress and anxiety, the job demands variables of workload and fear of COVID, the job resources variables of managerial and collegial support, human resources, and material resources, only one, managerial support, was a statistically significant predictor of nurses' turnover intentions in the Princess Margaret Hospital during the COVID-19 pandemic. I also found some correlations between the job demands, job resources, and well-being. For instance, managerial support and collegial support were negatively correlated with stress and anxiety, respectively. So that says to us, it said to me, that if nurses in this institution are supported by managers and colleagues in terms of physicians specifically, then that reduces their level of anxiety and stress as the level of support increases. Stress and anxiety did not mediate the effects of fear of COVID-19 and workload. Managerial support and collegial support on turnover intentions, but these were interesting findings, particularly based, like I say, on what I found elsewhere. And I'm going to talk about possible reasons why we had these findings. But before I do that specifically, I want to talk about some of the threats and then opportunities that I would have encountered during my planning and actual implementation of my doctoral research. So I actually started writing my proposal from the end of 2020, around some of 2020. And so it meant that I was all set. I knew what I wanted to do. I was looking at specific job demands and job resources and turnover intentions. And then when the COVID-19 pandemic hit and seemed that it was staying with us for an extended period of time, well, my supervisors and I decided that there was no way that we could talk about nurse turnover and not include COVID-19 context and what that would mean to turnover intentions with all of the things that had been happening. And so that also meant for me that I had to revise my proposal. And I'm talking about any number of things I had to change. I had to go back, review the literature. So that was a rapid review of the literature, which took another several weeks. Once I reviewed the literature, then it meant that I even had to go back and review my methodology, because initially my intent was to go into more traditional ways of going into the facility itself. In fact, I had planned to go into the facility as well as so do some face-to-face dialogue, distribution of my surveys, as well as I was also thinking about doing an online option. Well, of course, after COVID-19 hit, there was the lockdown, there were numerous restrictions. So it meant that I had to revise my methodology. So I went from perhaps in-person and a combination of online to strictly online. The revisions also took some time. So imagine now that I have certain timelines that I'm working with, but all of these additional variables, all of these extraneous variables, I would say, are now coming into play, that they are causing me to pivot, to make the necessary adjustments in order for me to move forward. So the proposal revisions, the restricted access, some things that I considered threats was the limited. Now, watch the word limited. I did not say that I had no access to. I'm saying that there is limited local and sometimes even regional academic support, depending on your area of research, depending on methodology, depending on the analysis that you would like to use. This limitation of local and sometimes even regional academic support can sometimes cause various delays, because even if you do have some support, because they all are already relied on so heavily from various individuals and even bodies, then it may take them longer to, sometimes they may be unable to provide assistance at that time based on their schedules and what's happening with them, or they may be delayed in their assistance and their responses. When these delays in responses also means delays, unmeant delays in me moving forward. Other threats, And this has to do with me because this is specific to my experience during the COVID-19 context in the island nation of the Bahamas. So what I found was variable and ambiguous policies and procedures. Now, this may not be specific to small island developing states or even this country, but I am saying what I found that were, quite concerning to me. So there were challenges with delays in the ethics approval. There was some, I think there needed to be clearer articulation and communication with what the ethics application was to conduct research in that particular organization, and even more broadly in the country. There are various steps that needed to occur prior to approval that I was not made aware of. I think in a timely fashion or even in a more organized fashion would have helped to move the process a little bit more quickly. So take for instance, and I know I'm not comparing apples with apples, but take for instance, my ethics approval at the University of Alberta took 5 working days. The ethics approval for the institution took an entire semester. Now, I'm well aware, and I do appreciate the fact that the persons that were responsible for the ethics approval in the country are strictly volunteers, and I was reminded of that on multiple occasions. And so sometimes things may change based on their schedules and all of the rest of it. So I think that when we are planning, if we are aware of some of these potential challenges at the beginning, you can plan better, because in research, as you're well aware, timelines are important. It matters with even your population under study, your target audience, who it is that you are trying to reach, when you are trying to reach them. The potential delays also impacts resources, and in some cases have the potential to impact study findings. And I said I'd talk about some of the surprising findings for me. So first of all, this taught me that you try to go in with a completely open mind. Now, because based on research that had been conducted around the world, I fully expected that high workload was going to negatively impact nursing turnover in this acute care facility in the Bahamas. That was not the case. I also thought that things like low job resources, like low material resources, low human resources, which have been a long-standing problem, not just in this country, but elsewhere. I fully expected that those variables would have also negatively impacted nurses' turnover intentions. That did not happen. Now, there are a couple of reasons why that is possible. I'll never know. But if I were to to just think about some things, the delays. So if a 4 or 5 month delay meant that by the time my study was conducted, the vaccines, in fact, multiple vaccines by then had become available in the country. The initial vaccine hesitancy that had been experienced by some of the healthcare professionals in the country by then had waned. And in fact, almost 85% of my study participants had were fully vaccinated at the time of the study. I say all of this to say that timing matters. And so it meant that as far as I was concerned, the delays threatened or potentially pose threats to my study findings, because if the fear of COVID would have been decreased at that time because nurses and other healthcare professionals, I'm sure, would have been feeling more comfortable because now they're vaccinated. Workload, even though they said that the workloads were high, they they said that they wouldn't leave because of the high workloads. And I'm thinking that perhaps by then the work content and context had become more normalized. Perhaps the workload would have been returning more to the pre-COVID level that nurses had become accustomed to, because nurses in this healthcare facility are accustomed to working hard, high patient workloads, and low material and human resources. So those are just some of the things. Now, even though there were some threats, there were a number of opportunities in my view. And so I had the opportunity to add to the body of empirical data. As I would have indicated earlier, there is a dearth of empirical data in this country specific to nursing. And so having the opportunity to conduct this research, even with all of the challenges, meant that I have been able to contribute to empirical data specific to this country and the country with regard to turnover, nursing in the Bahamas, and to provide some type of empirical data that speaks to what was happening with nursing during the COVID-19 pandemic. So I'm grateful for that. Additionally, what I found as an opportunity was my knowledge of the contextual settings and of the variables. So based on my introduction, you see I have a very personal experience with turnover in terms of even dialogue with colleagues, nursing and non-nursing, student nurses, my own personal experiences, an in-depth review of the literature. And so also having been not just born and raised in the country, but having worked and taught in the facility, it gave me specific knowledge of the contextual setting of, and I was able to leverage what one of my supervisors, Vera Kane, calls clinical currency. So because of my knowledge of how things operate, I was able to perhaps get some things done a little bit more quickly. This leveraging clinical currency is all about relationships. So, and in research, I'm sure you appreciate that in order to conduct research, it's about nurturing, fostering, building, and maintaining relationships. Good relationships are foundational. And so I had the opportunity to use my knowledge, and my committee were very big on encouraging me to use my knowledge of the context of the island, what happens there, how things are done in the context, so that I could move forward and get things done. And then opportunities for building research capacity were presented as well, because here, what I found was when my colleagues, current and former, when some of my former students and even current students, you know, and I had an opportunity to talk, they would ask about how my studies were going, how my research was coming along. And so I was able to say to them how important their participation was or is and continues to be in the research process, what it is that they can do to help to create and disseminate empirical data in this country and beyond, to help to us to further build capacity, to retain the human capital in this country and others, to ensure quality patient care. So those are some of the things that for me were opportunities, building empirical data in this country, and perhaps to assist with interventions beyond into the region, my knowledge and leveraging the clinical currency and leveraging the knowledge of the clinical context, and then the ability to build nursing research capacity in this country and perhaps to help with that throughout the region. So my key takeaway is that context matters. There is no value-free research, is what I found. No value-free research. Now, we, as much as possible, we position ourselves, we acknowledge some of our biases as we approach the research process, as we conduct research and even interpret and disseminate the findings. But context matters. Our personal context that we bring to the research process and how we conduct research, how we interpret and disseminate research, our professional context, and even cultural context. So the cultural context in terms of what happens, how things are done in a small island developing state such as the Bahamas, as opposed to other small island developing states, say in the Pacific. As opposed to how things are done in more developed nations that may have more established policies, procedures, have access to greater resources. So context always matters. Environmental context, in this case, when I conducted this study, it was the ongoing COVID-19 pandemic. And quite frankly, the COVID-19 pandemic continues. So it meant that nurses' work content and their work context, where they did their work, how they did their work, changed. And so context of our target population that we would wish to study, our personal context, more broadly, the environmental and cultural contexts all come together to influence the results. Social context in terms of norms, values, how we see health research, how we wish to utilize health research are all important, right? And so that is why I say context for me. I knew context mattered before, but having gone through this process and continuing to go through the research process and conducting other research, participating in other projects, I am realizing more and more that context and consideration of context, regardless of what that context looks like and what it means in your particular research, is very important. Because if you have a look at what I have on the slide here, we're talking about, it says, for a fair selection, everybody has to take the same exam. Please climb that tree. Now, when you look at that, all things aren't equal. There are various ways in which they might get up in the tree. And so that is what I want us to take away from this today, that there are various ways in which we might approach research, but context still matters. And so as I wind down my presentation, what is it, having said to you some of the things that I've experienced, and I say now, how is it that, what am I taking away from this to move forward as I continue as a researcher? So building local and regional research capacity is absolutely essential. And in so doing, we engender a climate that is conducive to conducting research in specific contexts. For me, it would be in this small island state. Now, if you recall at the beginning, I said that the Bahamas is not one continuous landmass. And that in itself, produces some challenges in terms of resources, conducting research, disseminating information, because of the various islands that we would want to tap in, particularly if we wanted to do, a national study. So we need to build more local capacity. We need to bridge gaps that are existent between clinical research and academic research. So we need to get together to ensure that we all realize that if we do this together, we can be better. What are some of the things that are important to you in clinical practice? What are some of the things that may be important to the wider community in terms of health, well-being, patient care? What are some of the things that are important to maintaining wellness amongst nurses, so that we're able to retain, maintain, and build a more robust nursing workforce in the country, or in whatever country, not just the Bahamas. So with that in mind, I'd like, since this is actually CASN, the Canadian Association for Schools of Nursing, I'd like to say to us as nurse educators that there are a couple of things that we can do to help to develop and foster the love of research and the appreciation of research in our students in which we come into contact, as well as our colleagues. And so you involve our students as much as possible in any research activity, and say to them that you begin small. Whether it's clinical research, community research, academic research, you begin small because every little bit counts. What I have also learned is that mentorship matters. Relationships are important. What I've been able to accomplish in my doctoral studies prior to, but particularly in my doctoral studies, since that's what I'm talking about, has been because of the relationships that I built prior to beginning my studies and that I've continued to maintain. Relationships with international mentors, like my committee members, my supervisors, and I see one of them has joined, Vera Kane, have been so important. So if we appreciate that we need to be more deliberate, more intentional about mentorship, and so there may be persons from countries that might, whose research capabilities and capacities might not be what they might be elsewhere. And so be more deliberate about mentoring those individuals who are interested, so that they are able to better help build capacity where they are at. Now, what we don't need is a savior, but what we do need is a helping hand to help build capacity through mentorship and other collaborative efforts to build the cadre of researchers so that we're better able to investigate and better understand community, clinical, and academic research, so that we're able to formulate interventions based on empirical data to support that. So, and with that, we're better able to streamline our processes to provide more robust nursing research as we move forward. With that in mind, I am going to ask that anyone who's interested in health human resources, specifically nursing workforce and well-being of healthcare professionals, employees, feel free, if you are conducting any research that you think I might be interested in, to contact me. I am very willing to partner with you. And it is my hope that this presentation will not be the last time that I am in contact with some of you. I am very interested in developing my program of research, PrEP, Policies to Retain Healthcare Professionals, and I do look forward to continued collaborative efforts. With that, that brings my presentation to an end. I do thank you for your kind attention, and at this time, I am willing to entertain any comments or questions that you may have. Thanks so much.
This meeting is being recorded.
Sorry about that, Dawn.
Thank you, Shamel, very much. Yes, so please raise your hand or just speak out there, and if you'd like, or something, put something in the chat.
Thanks, Shamel, for such, for me, it was very interesting because I am doing a doctoral study myself. And I'm looking at, I'm based in Canada, and I'm looking at registered nurse and registered practical nurse collaborative practice. So when I listened to your experience, I could pick out a few nuggets that speaks to me and my journey. And also thanks for putting it out there that I can connect with you as someone who have gone through the journey and could definitely, I could use some guidance as I progress towards my dissertation. One of the questions I wanted to ask is, I probably didn't catch it if you said it. Is it one category of nurses that work in the hospital in that acute care setting?
Okay, so thanks so much, Alicia, for your kind words. And you're correct, I didn't say it, but there are registered nurses and what we refer to as trained clinical nurses. So they would be almost equivalent to what the LPNs are in other healthcare settings. So I used both. So they're both regulated nurses in this country. And so all of them were able to participate in this particular study.
Okay. I
Yeah.
particularly asked because I know I'm looking at how both category of nurses practice and support each other in practice. And I know your study looked at, what are different signs or challenges that probably leads to burned out or, nurses not getting as much support in the clinical area. So that's what pushed me to ask you if there were different categories and how does that look? Is it the same feedback that you have gotten from both sets of nurses, or is there a difference, and how would you look at mitigating that difference if one did exist?
Okay, so thanks again for that next question, Alicia. So my primary research questions I was not seeking initially to differentiate staff. So first of all, I will say that I had more registered nurses participate in this study than the trained clinical nurses. In fact, I reached out because I really wanted to hear, particularly from the trained clinical nurses, what it is that they have to say. I don't think I have enough data to do a robust comparative analysis, but I can have a look at I can do some secondary analysis to see if there were differences in the responses between the RNs and what the trained clinical nurses had to say in terms of how the job demands, job resources may or may not have impacted their intent to leave, as well as how those things impact their well-being. But that was not the goal initially, but I do have enough data to perhaps, do some secondary analysis. But let's keep in touch, Alicia.
For sure, and thanks for doing it in a small region. And the reason why I said that is because I was born and trained in Jamaica before becoming a citizen of Canada, and so you're really putting that impression on me to look at smaller areas that really needs that kind of an investigation. So thanks for doing that.
Thank you.
Question P. Cash.
Very pleasant. Good afternoon to all. I am Dr. Paulette Cash, president of the Caribbean Nurses Organization, CNO, and a nursing supervisor at one of our public hospitals here in the Bahamas. And Dr. Sands, first of all, I would like to commend you for such an excellent presentation and also congratulate you on your successful completion of your doctoral studies. We are very proud of you as a nurse from the Caribbean region. Continue to excel and do well. I found that your study is very enlightening and it is of great relevance to the Bahamas and to the region as a whole, the Caribbean region, because we are seeing an increasing number of nurses who are leaving the Caribbean region, and that is of great concern to us because human resources is very important to ensure quality of care within our region. Of interest, in terms of your findings, I thought it very interesting that COVID-19 was not identified as a key predictor for nurses' intention to leave. And because if we look at the data for the Bahamas, what we would have seen is an increasing number of nurses who did leave during that period. Okay, so that was interesting. And I think that's an area that may need to be explored further as to what was the impetus behind those nurses, you know, leaving during that period. And it was also very interesting to note that the finding that managerial support mattered was a statistical significant finding in your study. And that has great implication for our workplaces and is something that needs to be shared within our healthcare institution and an area that really needs to be addressed. But thank you so much for sharing and continue to do well.
Thank you so much, Dr. Cash. And I'd just like to say that Dr. Cash has been one of the persons whose expertise and advice I was able to draw on while I was doing my doctoral research in this country in terms of perhaps how to move certain things forward more quickly. And because I had restricted access, she acted as one of the liaisons in the facility to help me to disseminate the some of the information in terms of the study and how it could be accessed and that type of thing. So I'd like to publicly thank Dr. Cash for her assistance and her continued support during this journey. Yes, Carol Mackey is one of my colleagues here from the university. Carol?
Yes, good afternoon once again. And I'd also like to say congratulations again to Chanel on your most recent accomplishment. Very good and continue to do well. The research project was very timely and also one that is needed for our region and our hospital. I want to piggyback on what Dr. Cash said in terms of your findings with managerial support. That was very interesting to me. My question is, did you find any other indicators of why managerial support was low? And
so Carol,
what?
If I'm understanding, you're asking if there were indicators as to why managerial support was low?
If you found any indicators of why managerial support was not there for a person.
No, actually.
The reason for the low managerial support.
No, actually, managerial support was high. Managerial support was considered, right? Yes. So this is what the study findings showed, that as nurses had, the higher the managerial support, let me put it that way, the higher the managerial support was, the less likely it was that nurses intended to leave the organization, right? So conversely, those who saw, whose perceptions that managerial support was low, they were more likely to leave. But nurses who felt that managerial support was high, they were less likely to leave. They were more likely to stay because of managerial support.
Okay. Thank you.
Is that clear, Carol?
Yes, my audio is in and out, so at times I wasn't hearing clearly, but thanks.
Okay, thank you.
Just curious, John, how did you measure managerial support? Was there a tool that you used?
Yes, so managerial support was used there, I'm trying to remember the exact name now, Dawn, pardon me.
Oh,
But-
that's fine. No.
But I did use the tool. Oh, I don't know why. Just because you asked now, I can't remember the name of it.
That's fine. That's fine.
But it had to do with, is it Lake? The tool created by Lake, where she talks about what needs to be present in a practice environment for nurses, right? That represents good practice work environment. And some of the questions in the tool speaks to whether or not that manager is seen as supportive. If that manager uses issues or challenges as learning experiences instead of just to critique. If the managers support nurses even when they are in conflict with physicians. Those were some of the questions in that tool. There were about 6 or 7, about 6 questions that spoke to direct managerial or supervisory support in terms of how it helped with their work and how it helped with relationships with physicians. Yeah, and so that tool had not been used previously in this country. So I got permission I did a pilot study of a group of nurses employed in the organization prior to using the tool. So, and had excellent, alpha was 0.9 something. So I feel pretty good about the results from that.
Thank you.
Thank you.
We have a few minutes left before the top of the hour. Anyone else want to have a question or say statement? Dr. Munnings?
Good afternoon.
Oh.
Congratulations, Dr. Sands, on your accomplishments and on an excellent study. My question was the question that Dawn asked about the study tool. I remember seeing it when you did your first test, but I didn't remember the name of the tool. So just couldn't find the hand raised. I can't. But congratulations, great study, very well presented. And it certainly has implications for us here as managers within this hospital and the region. You know, it makes us think more of our actions, even while we're in the middle of it, our actions and conversations to ensure that our staff feel the support that we give. So excellent presentation, and I am sure this goes a long way to improve relationships. And I too was a little, it was interesting to find, your findings were interesting, and it's great that the study was done by someone who grew up in the environment to be able to see it in the proper context. So I pray that you continue to do well in all of your endeavors.
Thanks so much, Dr. Munnings. And Dr. Munnings is also a colleague and friend of mine from the Bahamas that I've known for a number of years. And I also we rely on each other. And you see, that's why I say that relationships are so important, fostering, maintaining those relationships. And I will say that I am in the process of actually putting together an executive summary so that I could send my study findings to the nursing and hospital administration. But I thank you so much for your interest in my work and for this opportunity to present. And Dawn, mentorship and relationships are so important because you and I would not have met if it weren't for one of my supervisors, Christine Corvell,
Yes,
who
that's
suggested
right.
that I might be the one instead of her to present at Casson Lunch and Learn. So I'd like to thank you as well for following up.
No, that's my pleasure, for sure. So thank you for your presentation, and thank you to all who registered for the webinar. So the link of this recording will be automatically sent to those who have registered, and please feel free to share within your networks. Thank you for joining us, and please consider joining us for our next Lunch and Learn on May 17th, when Dr. Sylvain Brosseau will present Organizational Humanization and its Benefits for the Quality of Care and the Quality of Life at Work for Nurses, a Qualitative Metasynthesis. So you can go to our website and register for that course as well. So thank you all once again, and have a good rest of the day.